think with this, I think Sharmila is eagerly waiting, sir. Shall we go to her talk? And we always wanted to hear from her. We cardiologists many times come across with coronary artery disease post-MI, and to do stenting or not, whether it's viable or not, sometimes PET-CT, sometimes MRI. We wanted to hear from her what is the best. Over to you, Sharmila.
Perfect. Thank you so much. Are you able to see my screen now?
Yes, perfect.
Perfect. Thank you so much. It's really a pleasure for me to be presenting about myocardial viability. My task is to talk about what is a gold standard test for the assessment of myocardial viability. These are my disclosures, none pertinent to this talk. So to start with, what is viable myocardium? Viable myocardium is hibernating myocardium, which is dysfunctional and has the potential to improve function after revascularization. It's characterized by an improvement in contractile function with reperfusion or with inotropic stimulation, and a switch from fat to glucose metabolism accompanied by a reactivation of the fetal gene program. So what's the rationale for viability imaging? Primarily to identify patients who are likely to benefit from high-risk coronary revascularization procedures by identifying viability, by defining the amount of scar, hibernating myocardium, by looking at the amount of ischemia, as well as by defining myocardial remodeling. So to start with, I wanted to present a case, an 86-year-old man with days to weeks of shortness of breath and chest pain. His risk factors were high blood pressure and diabetes. ECG showed evidence of a recent inferior wall myocardial infarction. And he had abnormal troponins, high NT-proBNP, and his estimated GFR was 51. Here's his rest N13 ammonia PET study showing a massively dilated left ventricle with perfusion defects involving the septum, involving the inferior and infralateral walls, as well as the mid to apical anterior wall and apex. And the question here is, are these hypoperfused segments viable? So this patient went on to have FDG PET for assessment of viability. And what you'll notice is the septum, as well as the mid to apical anterior wall and apex, show what is called a mismatch. Mismatch, which is reduced perfusion, but preserved utilization of glucose. Similarly, the inferior wall also demonstrates a mismatch pattern, suggesting that the myocardium is viable. In fact, if you look at this particular FDG image, you'll get a sense that most of the myocardium in this particular patient is viable. So he also went on to have an MRI study, and this was primarily because at age 86 with the recent MI, there was a concern that he is very high risk, and there was a concern that the FDG may represent increased uptake related to inflammation and not necessarily viability. And here's MRI images with late gadolinium enhancement showing subendocardial late gadolinium enhancement in the inferior wall, whereas a little bit closer to 50% or more late gadolinium enhancement in the LAD territory, particularly the apical septum and apex. And this area also looks thinned out. This is the function on MRI, and you can see a dilated ventricle with severe global hypokinesis and akinesis of these territories with an ejection fraction of 16%. So this is just showing you what the PET perfusion shows and the corresponding late gadolinium enhancement. This is the PET perfusion with late gadolinium enhancement, and these are the FDG images identifying that despite hypoperfusion and some amount of subendocardial LGE, this territory is all viable. So patient went on to the cath lab, and he had complex disease with 100% occlusion of the right coronary artery and very tight stenosis of the LAD, as well as disease of the circumflex. So both vessels were percutaneously revascularized, and this is his ejection fraction 6 months later, showing improvement of LVEF to 40% from about 15 to 20% EF. So what are the cardiac metabolic changes in hibernating myocardium? So the primary pathology in ischemic insult to the heart is a problem with circulation or perfusion to the heart muscle. That leads to a series of changes in metabolic processes which eventually result in contractile dysfunction. So perfusion abnormalities are initial changes, metabolic abnormalities are subsequent changes, and contractile function is a late change in the process of ischemic dysfunction. And of course, scar indicates irreversible change. Therefore, any technique that relies on imaging perfusion is likely to be sensitive. Any technique that relies on imaging contractile function is likely to be more specific. And of course, scar indicates that this area is unlikely to recover function. So a number of tests are now available to image this. You can look at perfusion with SPECT or PET tracers, metabolic imaging with F18 FDG, contractile reserve with low-dose dobutamine echo or MRI, imaging of scar with late gadolinium enhancement with MR imaging, looking at myocardial remodeling with MRI or echocardiography. So when you look at the relative sensitivities, you'll notice that radionuclide methods are slightly more sensitive compared to contractile function assessment, and contractile function assessment relatively more specific compared to perfusion as well as other methodologies. So one more case here, a 51-year-old man with out-of-hospital cardiac arrest, severe multivessel coronary disease, which was not amenable to percutaneous intervention. He was having frequent ventricular tachycardia. So after 3 weeks of stabilizing him, he underwent rest-stress perfusion with N13 ammonia. You can see a dilated ventricle with severe perfusion defects in the inferior infroseptal walls, showing partial reversibility, as well as a perfusion defect in the anterior anteroseptal apical myocardial segments in apex, also showing some degree of ischemia. FTG imaging shows significant mismatch in the inferior territory, reflecting likely both hibernating myocardium as well as ischemia in this territory. So after a lot of discussion, this patient was referred for bypass surgery. He had, unfortunately, a very prolonged postoperative course with multi-organ failure and did not survive the procedure. So this was a 51-year-old with really not many other options, and bypass was performed as a last effort to save some of his myocardium. So at autopsy, you can see this is the cross-section of the heart. There's all these inferior evidence of inferior infarction. And you can also see patchy areas of infarction in the anterior wall, but most of the myocardium was otherwise viable. So the question is, why did this patient do poorly after surgery despite presence of viability? So a lot of other factors beyond viability will determine patient outcomes. Patient risk for surgery, time to revascularization, suitability of the target vessels for revascularization, of course, absence of myocardial viability, baseline LV ejection fraction, the magnitude of myocardial scar, as well as the degree of LV remodeling. So this is data from Dr. Rob Bainman's lab from a study that they performed years ago, showing that the absolute change in EF after revascularization is small in patients with a large amount of scar, and this is not surprising. There's also data to suggest that in patients who have a low EF and who have a very remodeled ventricle, so this is an example of a patient with severe anterior septal defects, showing presence of viability but FTG, but a very remodeled ventricle. So data from Dr. Jerome Bax and colleagues from Leiden actually shows that even in the presence of myocardial viability, if the patient has a very dilated ventricle with an end-systolic volume of more than 130 in this particular study, these patients have a high rate of cardiac events. This is another study, which is a prospective randomized study of 428 patients, all with EF less than or equal to 35, looking at outcomes of cardiac death, MI, hospital stay for cardiac causes. And in this particular study, patients were randomized to a PET strategy versus a standard strategy. The primary endpoint was now different between the two groups. However, when the investigators looked at what they call PET adherent, which is PET showed viability, patients were revascularized, PET showed no viability, patients were not revascularized, that particular group, the FTG PET adhere group, tended to have better event-free survival compared to the standard group. Of course, the STITCH viability study, most of you are familiar with, was the STITCH itself. The primary study was a randomized study of ischemic cardiomyopathy patients with EF less than or equal to 35%, with coronary anatomy suitable for bypass surgery or medical therapy. This was the randomization. The viability sub-study of STITCH was not a randomized study. It included nearly 600 patients. And the findings of this study at 10-year follow-up showed that patients who were randomized to bypass plus medical therapy had a survival advantage compared to patients who were randomized to medical therapy alone. However, the findings of this study did not support that viability was associated with a long-term benefit of CABG in patients with ischemic cardiomyopathy. The side point from this main study, they showed that in patients with myocardium that is viable, the ejection fraction change was higher both with medical therapy and bypass, suggesting that viable myocardium may be good for preservation of LV function eventually. There are a lot of points for discussion on this particular study, including the fact that the techniques used for viability were not optimal. Nearly 80% of the patients were deemed to have viable myocardium, and FDG PET and MRI, which are the current reference standards for viability, were not used in this study. So despite all of this, the data suggests that presence of viability may be good for preservation of left ventricular function. In addition, this is data adding to what Dr. Taketi had nicely shown in ischemic heart disease, looking at the incremental value of flow reserve. So in this study that was recently published in JACC, 254 patients underwent stress rest MPI and viability, looking for major adverse cardiac events. And they showed that ischemia and hibernating myocardium did not predict events in the study, but myocardial flow reserve, we look at here, less than 1.2, really identified patients who benefited from early bypass surgery, both compared to medical therapy and compared to early PCI. So this is again an observational retrospective study, but data like this suggests that flow reserve and quantitative PET metrics may better identify patients who are likely to benefit from revascularization. So to summarize, what's the gold standard test? I think viability testing is probably not routinely necessary for all patients, particularly in those patients who have angina, LV dysfunction, anatomy suitable for coronary revascularization. You could straight away consider them for revascularization without viability testing. Imaging is reserved for patients in whom management decisions are difficult, particularly the older individuals with comorbidities, complex coronary anatomy, and where additional information may be helpful to guide therapy. In addition to presence of viability, consider other factors that we discussed: time to revascularization, suitability of the vessels for revascularization, baseline ejection fraction, magnitude of scar, and degree of LV remodeling. So what is the gold standard? For ischemia testing, radionuclide imaging, cardiac MRI, or echocardiography. Cardiac MRI is the reference standard for measuring scar because it can detect subendocardial scar and quantify it. For hibernating myocardium, FDG PET is the gold standard. And for assessment of myocardial remodeling, it's either echo, MRI, or you can even get volumes in EF with radionuclide techniques. With that, I would like to thank you all for attending this session and open for any questions.
Very clear for all of us that if you have to detect scar, you do MRI, but if you have to detect looking for viability, it is PET. And finally, some of the situations where comorbidities and other things are involved, you also should be taking care of the entire scenario of the patient. I think you highlighted those things very well.